Thank you, Fiona, for your kind introduction and for inviting me to talk at this webinar. This webinar is addressed to primary care doctors and physiotherapists who deal with musculoskeletal problems. And I will talk today about the young arthritic knee and methods of treatment while preserving the joint for the young arthritic knee. This is a topic of interest to you as a primary care doctors and as physiotherapists, not only for your patients who come to you with arthritic symptoms, but also for most of us who have played sport, who have had possible surgery to our knees, who will contemplate to lead an active lifestyle with symptoms and developing degenerative changes in our knees. So I hope you'll find this presentation useful. So as mentioned, I will cover the young arthritic knee while preserving the joint, and my colleague Mr. Gavin McHugh will cover the not so young arthritic knee. My name is Vioreanu. I work in sports surgery clinic for 6 years, and as it happens, myself and Gavin share an office, so we closely work together looking after the patients, and our philosophy of treatment is quite similar. So why is this so important? It is because epidemiological data and demographical data, published data from US, it tells us that 1 in 2 Americans will develop osteoarthritis in their life. That is possibly due to baby boomers reaching nowadays over the age of 70. And also has to do with the fact that since the increasing of using of the MRI, the arthritis is being diagnosed much earlier than, let's say, 1990s. So based on those data, the forecast in the US is that we will be doing in 10 years' time 7 times more knee replacements. And that is almost half of those knee replacements is expected to be done in young patients, younger than 65. So how are we going to treat these knees before they get to the stage when they need a knee replacement? And we learned the hard way, and there's a lot of data showing that doing a keyhole surgery, doing an arthroscopy in patients who have arthritis, it doesn't work. There have been a number of randomized control trials, published evidence, strong evidence, than doing an arthroscopy and washout on the arthritic knee. In fact, that arthroscopy, although it's been portrayed as a small surgery, could be a significant injury to the knee, and a significant percentage of those patients do get worse. At that point, the surgeon, having seen the lack of cartilage in the knee through the arthroscopy, is tempted to propose the next stage to do a knee replacement in a young patient. And a significant percentage of those knee replacements will go and being painful knee replacement. And that is a big problem for everybody: surgeon, patients, family doctor, physiotherapist. This is one article that I picked up that was published in 2013. It's a controversial article. It was published in New England Journal of Medicine, where they looked at performing an arthroscopy, not even in the arthritic knee, even though the cartilage was well preserved, performing an arthroscopy and comparing it with so-called sham surgery. And that is, they actually did the arthroscopy, they put the shaver in the joint, and they shaved just the fluid. They didn't touch the degenerative medial meniscal tear. And the 2-year study results came out saying that there was no difference between the 2 groups. In other words, patients who had both groups got better. They improved their symptoms by having an arthroscopy, but there was no difference between the group that the meniscal tear was taking out or the group that the meniscus was not touched. Now that sparked a good bit of controversy in the orthopedic world, mainly because there was criticized because of selection bias. In other words, the patients included in this study were patients who were for 3 months not getting better with conservative treatment. Patients who had a frank meniscal tear that needed surgery, they were not included in this group. And that also, there was some crossover. In other words, patients who had the sham surgery continued to have symptoms, and they needed to have a proper meniscectomy. So that sparked a bit of controversy. And interestingly, the reason I'm bringing this up in the context of developing arthritis is that last month, the 5 years follow-up of this study came out in Journal of British Sports Medicine. And it showed that at 5 years, between the two groups, there was no difference. And in fact, people who had the meniscectomy increased their chance of developing arthritis at 5 years. On this context, the American Academy of Orthopedic Surgeons, they looked at all the available evidence in 2013, and they published that report. This is a huge body of work, and it's important to mention that it's done by the surgeons in the United States, where is a significant proportion of private practice. So they looked at all the available evidence. They looked over 10,000 studies, and I flicked through the report that has 1,100 pages on. So what did they classify the evidence of being strong, intermediate, or inconclusive? So this is, and then they published the report, and this is 2 slides. I try to summarize it for you. So first of all, what they did not recommend for the treatment of arthritis is, as I mentioned before, doing an arthroscopy, and the evidence for that was strong. And I will go through some of those methods of treatment that were not recommended by their work, by their report. And the one-liner for glucosamine and chondroitin and fish oil that I often use with patients is like eating brain to get smarter. Just taking pills of glucosamine or fish oil doesn't mean that the cartilage that we're ingesting goes into the knee. In fact, there is no evidence that will grow back the cartilage. Interestingly, hyaluronic acid, which is a well-recognized method of treatment, and I used as well in combination with steroids to act as an anti-inflammatory in the setting of osteoarthritis. In 2013, the evidence was strongly against using it. The other methods that I use in my practice is medial compartment unloader braces, which I'll talk to you a little bit about it, and the evidence is inconclusive. The steroids, the evidence is inconclusive. However, in the right clinical setting with the right patient selection, it does calm the joint and helping the patient. And I use it with hyaluronic acid as a medium rather than local anesthetic. And the interesting factor about stem cells, growth factors, platelets-rich plasma, there is not enough evidence to suggest that this should be used in clinical practice. As I mentioned, I do use the braces, but these are not simple knee braces. These are specialized braces that work static or dynamic, as you can see here. And mainly what they do, they unload a particular compartment of the joint. So I ask the patients to use them to unload the compartment of the joint that is affected by the degenerative changes with arthritis. And they use them when they exercise, when they play golf, when they walk. And in conjunction with applying an injection with hyaluronic acid and steroid that modulates the inflammatory component of their knee, I find that works quite well. That's an interesting paper that I want to draw your attention to, and that is about the stem cells. This is published only in February this year, and is an annotation in Bone and Joint Journal. And interestingly, the authors of these annotations are all members of the Biologic Association. So they're all people who have an interest in biological research. And what they say mainly in their annotation is that they draw attention to the significant rise of clinics who recommend stem cell usage. And often this nomenclature, the way they advertise it's their treatments, and the way the evidence on which they base their recommendation is questionable. So we have seen in Dublin, in Cork, such clinics, and I would be very cautious in using any terms like regenerative medicine in clinical practice. At the moment, we don't have enough evidence, scientific evidence, to support its use. Even these authors who are big promoters of biological and regenerative medicine accept that this is experimental at the moment. It should be used as an investigative therapy, and therefore should be provided at a reasonable cost, with clear explanations about the evidence, existing evidence on their use. So their message is that the resurgence of these clinics, and mainly for marketing various practices, is in fact hindering to the development of research, to getting grants. And that topic in itself is worth a specific webinar, so I'm not going to continue on that. So it's a bit sad that in 2020, the only treatment for early arthritis is get on the bike, lose a bit of weight, and take an anti-inflammatory where you have the pain. But essentially, this is what the evidence show, that we have strong evidence to support that, maybe put a different way, unloading the joint and strengthening the muscles around the joint helps with the symptoms. And that's what I advise my patients. Unloading the joint to various methods, being an unload or brace, or being losing weight, or even changing the way they're exercising. Running, it's not a great exercise on a knee that's suffering. Running is great for normal knees, but on a knee that's suffering, on a knee that's degenerative, that had a meniscal tear, that had surgery, running is quite demanding. So I advise all my patients to get on an exercise bike, to get cycling, to get swimming. Rowing is an excellent exercise. Even walking could be quite the loading type of exercise. For the physiotherapists out there, I always advise my patient to change their routine from exercise routine from a loading type exercise to resistance-based exercise. I help them with prescribing an anti-inflammatory, and I use Vimovo because it has a gastric protector in it. I always direct them to have at least been supervised by a physiotherapist or a strength and conditioning. So the alternative to all this is really to have a knee replacement, or at least that's what we thought. And we know that knee replacements in the young population, in younger than 65, 20% of the knee replacements are not happy with their results. And which is 1 in 5, which is a high figure. If I would sit in my clinic for every 5 patients that I do a knee replacement on, 1 being unhappy, I would have a long days in the clinic. And I think this is an important graph. It's taken from the Australian joint registry, and it shows that the majority of patients who fail their knee replacement, it happens in the first 2 years. And the younger the patients are, and the green line is the less than 55, the earlier they fail. And they don't fail because we use the wrong implant. They don't fail because we we put them the wrong way, we use exactly the same implant. They really fail because it's a mismatch of expectations. In other words, the patients expect they're gonna, at the age of 50 or 60, they're gonna continue doing what they would like to do at that age. Whereas the knee replacement really, it gives patients who are at the age of 70 to lead an active life for that age. So I guess this mismatch of expectations sometimes could stem from the insufficient patient education. In other words, we don't, as surgeons, spend enough time trying to explain to those patients what is it to have a knee replacement and how that impacts in their future activities. And on that regard, I wrote I have a specific booklet that I give it to him, to the patient, to see, is it the right time to have a knee replacement? And when is this time to have a knee replacement? And generally, this is a great graph that explains that the time to have a knee replacement is whenever their quality of life is sufficiently impacted by the symptoms caused by their osteoarthritic knee. And that is a very subjective, quality of life is a very subjective measure. So generally, what I tell the patient is whenever they forced to give up social activities, whenever they have problems sleeping, and whenever, of course, we have exhausted all the conservative measures, then we can discuss about having some sort of form of knee replacement.